So good evening, and let's start now. And of course, this session is not gonna go without your interaction. So feel free. I'm not gonna choose by the show of hand. Whoever thinks is okay to answer, comment, or ask questions, just go ahead. Some of these images you probably have come across before, because I think part of the videos here I have discussed with you before. Okay, so this is a patient, as far as I remember, was 45 plus, hypertension, diabetic, and has end-stage renal disease on hemodialysis. So he came in as part of evaluation for kidney transplant. We did the echo on the left. What does it show? What do you see here?
الو السلام عليكم دكتور حاتم.
وعليكم السلام، كيف الأحوال؟
Yeah, this first image show typical four chamber view. Right, there is I think moderate severe MR.
Okay.
The patient.
Okay.
Also LV there.
And the LV is what?
Also dilated.
Very good. So yeah, we can observe that the LV is dilated and is impaired significantly, probably LV dysfunction, ejection fraction in the range of 25-30 maybe. And like you said, there is significant patch regurgitation. And this is a zoomed in frozen image of the MR, which is significant. So what is gonna be the best course of action? Remind you, this patient came in for evaluation for kidney transplant. Sorry?
Yes, appreciate that he came for evaluation for renal transplantation. Yes.
Yeah.
But I think he has very low ejection fraction.
Okay.
The severe mitral repair. He might be not candidate for transplantation, cannot tolerate the operation, I think.
So you think at this stage the patient is not fit, or he is high risk for surgery?
Operation. Because also left ventricle is dilated.
Dash what?
Dilatation of LV also.
Yes. Okay. So you are gonna ask to postpone surgery, pending what? Are you planning to do anything? Yes. Yeah, I agree with you. This patient is high risk, and it's not wise to go for surgery at this stage, given the LV dysfunction, which is severe, and the significant mitral regurgitation. But if this label of high risk is sticky enough to put him off the list of transplant once and forever, or probably you are going to do some kind of management with the view
repair to surgery for repair or
replacement of the mitral regurgitation. Okay, so this is again important, but it is a question. The question of surgery here relies heavily on whether the MR is the cause or the effect.
Yes.
Is the MR the cause of LV dysfunction, or the MR is the effect of LV dysfunction? So what do you think from these images? I don't give you enough images. Yes?
I think
Yes, go ahead.
Hello.
Hello.
أيوة. Dr. Iman Ahmed. I think this patient uremia is the cause of severe MR. So this patient need dialysis and then assessment after that.
Okay. So you will not rush for surgery or any other intervention.
At this stage.
And you are going to address the metabolic derangement, and you are probably going to advise dialysis or escalation of dialysis, and you're going to follow the patient up in few months. And this is exactly what we have done, and this is exactly the right plan. And in 2 months' time, this is the MR, which is now mild, and I didn't show you the LV function good, but the LV function has improved to nearly normal ejection fraction. After dialysis, okay? This patient was not on dialysis. He was, I think, chronic kidney disease stage 5, and he was referred for preemptive transplantation, okay? So we advised to start dialysis, and they started dialysis, and here what we get. But sometimes, even if the patient on dialysis, you can advise intensification of dialysis in terms of duration and or frequency, and then you follow the LV function down the line, because this cardiomyopathy is potentially reversible. But in some patients, we need to go ahead from the outset to rule out ischemic heart disease. But this patient was not the candidate, because I think there was no symptoms, stuff like that. And so, and he had very gross metabolic derangement, and he was resisting dialysis initially. So when we put him on dialysis, that's what we get. But it's wise to rule out ischemic heart disease in appropriate patients who have high risk and stuff like that. You can do that invasively or non-invasively, depends on your pretest probability. On your pretest probability of ischemic heart disease, okay? But this case underscores the importance of reversible cardiomyopathy, and not all cardiomyopathy you are dealing with demands immediate intervention or surgery. Sometimes you have to probe in the radical causes, see what might be causing this cardiomyopathy, and treating it and following the patient up down the line. One of these cardiomyopathies is this cardiomyopathy, which is related to the kidney failure, renal failure, cardiomyopathy, cardiorenal syndromes, and stuff like that. So in these patients, it's wise to give them a chance of medical therapy and follow up after you rule out ischemia in some selected patients. Okay?
Okay, thank you.
Okay. So we move on to the next patient. So this is one of the mechanical complications of myocardial infarction. So what is this?
Hello.
Hello?
Okay. This is the parallel 2. This is transesophageal because chamber 2 show a flail anterior mitral part lifted due to rupture papillary muscle.
Very good. Very good. Yes. You are so right. Yeah. So you see here, you see the anterior leaflet is holding something, you know, this is the head of the papillary muscle. You can also see it here, and you see because the LV is too weak, but you, if you give attention enough, you pay attention enough, you might see that the anterior leaflet is going into the left atrium in a flare sort of excursion. And here is the MR, which is more posteriorly directed because of the flail anterior leaflet. And of course, the 3D is going to give the answer, where you can see the anterior leaflet, which is here, and you see that there is flail of the anterior leaflet with a cord. This is the cord, and the head of the papillary muscle on the tip. Okay, so this is ruptured papillary muscle. So what is the onset, expected onset of this complication? Is it immediate with the MI at the onset of myocardial infarction, or a bit later, weeks, days, months after MI?
Maybe after 24 hours.
24 hours, or we can
Or
say
48
3 to 7 days. 3 to 7 days. They start most likely after the 3rd day. Why not immediate?
Because early the necrosis is not occurring.
Exactly. Exactly, because it's a matter of necrosis, myocardial injury and necrosis, which takes a bit of time for it to get complete and liquefaction and maximum, and leads to this kind of ruptures and perforations. So it takes time. So it's not immediate. So mechanical complications are not immediate, meaning they are not within few hours of the myocardial infarction, but rather in few days. Now, if you examine this patient, because he's hypotensive and had pulmonary edema on chest X-ray, so you examine his precordium, what are the expected signs you are going to pick in this patient?
I find a sign of heart failure from side congestion. I'm not expecting to hear about systolic murmur. And his main issue is a cardiogenic shock.
Okay, so you said you are not expecting to hear a loud pansystolic murmur. Why?
Because of the poor LP function and other things, the mechanism.
And? You remember the classic teaching is that the loudness of the murmur does not reflect severity of the valve disease. Okay, this is a classic teaching, and it is so applicable here because the MR is severe like the one we see here, but when you put your stethoscope, you will be embarrassed that you are not able to pick even a soft murmur. Sometimes you can hear a soft, short-lived murmur, or sometimes nothing at all. So the intensity of the murmur does not reflect severity. And here why? Because the intensity of the murmur relates to the velocity of the jet. Intensity equals velocity. And velocity equals what? Equals gradient between the LV and the LA. So if we are talking about MR, then the MR velocity depends on the LV LA gradient. In cases of myocardial infarction and papillary muscle rupture, the LV is weak because of the myocardial injury. The ejection fraction is low. So the pressure here, the pressure on this chamber is low. And then when you come to the left atrium, because this event is acutely, so expected that the left atrium is a small size and not dilated yet to adapt for the MR. So I'm expecting that the pressure here is high and it's gonna rapidly equalize the jet. Okay, so the gradient, the LV-LA gradient is low. That's why the gradient is of soft intensity and short-lived, not even of long duration. Okay, so this is important to know, that the clinical detection of papillary muscle rupture is challenging. Okay, And that's why you have to go for transthoracic echo. And believe it or not, sometimes even you can, if you are not careful enough, you can miss it even by transthoracic echo, and you will only see it in TE. Okay, because even in transthoracic echo, the jet might be, because we said that it is of low velocity and short-lived, you might miss it. Okay, you might miss it. And this ruptured papillary muscle and head, not so easy to see sometimes. It's not easy to see, especially in patients expectedly in cardiogenic shock. Because of this, they are probably intubated and mechanical ventilation. So that's going to compromise the image quality of transthoracic echo. So if whenever you have suspicion of papillary muscle rupture and transthoracic echo was not the answer, you don't have to close the case at this stage, but it's better to go for TE. So, you know, you never close the case at transthoracic echo, and definitely you are never going to close the case at clinical data level. Okay. Now, I would like to contrast the papillary muscle rupture with ventricular septal rupture. If I have ventricular septal rupture here, because of myocardial infarction, I'm expected to have a loud intensity murmur and even thrill. So why here is the difference? Why? Because the LV-RV gradient is still higher. LV-RV gradient is higher than LV-LA gradient. And we said that the velocity of the jet determines how loud you can hear the jet, or you can hear the murmur. Okay, so always think of it in this term: the velocity, and the velocity means gradients between two chambers. Okay. Okay, so what do you see on this transthoracic echo on the left? Okay. Anything?
Okay, this is four-chamber view, apical four-chamber view. Show severely dilated left atrium and left ventricle, and the mitral valve, the posterior mitral leaflet is prolapsing,
Okay.
with generating severe mitral regurgitation and hypoplastic
Hypoplastic what?
and I think the second view is the TOE.
Okay.
I'm not sure which leaflet, but I think one of the leaflet is hypoplastic to severe mitral regurgitation and the other is prolapsing.
Very good. Very good. So I'm going to give you a short history, clinical history. This is a 16-year-old gentleman, and or a boy, whatever, and he presented with convulsion. Okay, his initial presentation to ER was convulsion, and he transpired to have fever on and off for the last few days. Okay, so they did CT brain. They found a bleeding aneurysm. So as part of the workup, because he also showed, I think it was a strep viridans or one of the streps group blood culture, they asked us to do transthoracic echo. We did this transthoracic echo. So now, in light of this clinical history, how are you going to report this echo? The patient came in convulsion due to bleeding cerebral aneurysm. Okay. He has fever with positive blood culture, and this is the transthoracic echo. There is no clear vegetation here, honestly speaking, not even in transthoracic echo here. But most likely the case is of infective endocarditis. And we describe this valve as rheumatic valve. It is rheumatic. Look at the tricuspid valve on the right side. You see here, the tricuspid valve is also thickened and rheumatic. Now, that might not strike you as typically rheumatic morphology. I agree. Doesn't look so much like rheumatic. But why is that? Why?
It's mixomatous.
Huh? Simply because of the overlying pathology. Now it's not rheumatic, but there is a flail leaflet. Yes, there is a flail rupture, anterior leaflet, chordal, a cord with a flail anterior leaflet generating this severe mitral regurgitation. Okay, and we also have seen in this patient perforation. So we have perforation and rupture cord. Remind you, if you are looking for major criteria for infective endocarditis, is not only the vegetation. It's not only the vegetation. If you see vegetation, if you see abscess, if you see new paravalvular leak, if you see perforation or chordal rupture. So these are all goes into the echo parameters of infective endocarditis. Okay, so our diagnosis in this case, though we did not see the vegetation, is infective endocarditis. Patient received antibiotic course and improved a lot, and he even went for surgery for his mitral valve. Okay, surgery for the mitral valve successfully and eventfully. So the importance of this case is to remind you that when you are looking for the diagnosis of infective endocarditis in echo, don't focus on vegetation and don't be turned down or turned off whenever you find no vegetation, meaning no infective endocarditis. No, that's not right. So there are some other features of infective endocarditis in echo you should look for, like the paravalvular leak, like the perforation, the cord, and any other type of valvular destructions. Okay, and the other thing is that you also have to remember, sometimes echo is not the last. Echo is probably always the first in the diagnosis of infective endocarditis, but it's not always the last. Yani, there are so many cases, I wouldn't say so many cases, but there are some sizable number of cases in which the diagnosis of infective endocarditis is not settled at transthoracic or TE level, and you have to go for CT, PET, and SPECT, and all these kind of advanced imaging. Okay, upon which the diagnosis of infective endocarditis is established, not before that. So echo is the first, but not the last in the diagnosis of infective endocarditis. Okay, so remember this. Now, this abnormality, which you see in this echo, can be associated with all except severe MR, Lvo Tube obstruction, apical thrombus, normal coronaries, severe aortic regurgitation.
Okay, we can take it individually. This echo show a severely dilated left ventricle with apical akinetic apex and looks ballooning. So the severe MR can do LV obstruction. I'm not expecting to Lvo Tube obstruction, not expecting there is a hookah or something like it. Apical thrombus, I can found it. Normal coronaries could be. and severe could be.
Okay. So you are ruling out LVO tube obstruction, huh? Right? Okay. So, like you said, this is LV dysfunction, and you see this kinetic or akinetic apical aneurysm. And it is actually larger than only apical aneurysm because it involves also part of the lateral wall and inferior septum. So this is big. And actually, it's only the basal contractors which have sort of hyperdynamic contractility here. But the mid downwards is the akinetic, right? Okay, right, yes. So this is a picture of cardiac infarction, ischemic cardiomyopathy, but it may well be a picture of stress-induced cardiomyopathy, right? Stress-induced cardiomyopathy or anterior myocardial infarction. Okay. Now, with this apical aneurysm and with this basal hypercontractility, what you see here, can you have LVO tube obstruction? Can you? Yes, you can. And I want you to remember this very well, that with myocardial infarction, anterior myocardial infarction, and with the stress-induced cardiomyopathy, and with this kind of damage where the apex is akinetic or aneurysmal, and there is hyperdynamic base of the heart, Venturi effect might be generated or induced, and that can suck the anterior leaflet into the LVOT, causing obstruction. So LVOT obstruction is one of the mechanical complications of MI. You have to remember this. One of the mechanical complications of MI is the LVOT obstruction, and that's usually you forget about. Usually you forget about that. I remember one time there was a patient after myocardial infarction. It was massive anterior. He underwent coronary angio timely and successfully for PCI to LAD. And then in the CCU, he went into pulmonary edema and hemodynamics and stuff like that. So they started giving him inotropic support, and that didn't help. And they call us to do transthoracic echo or to do TEE to rule out mechanical complication. And so the fellow went to do TEE, and he sent me the images that everything is fine. There is no MR, there is no papillary muscle rupture, there is no VSR. So things are fine and no mechanical complication. And I looked at one of the images of the long axis TEE, and I see that there is clear SAM. The systolic anterior motion of the anterior mitral leaflet was closing the LVOT, and he just overlooked it. Overlooked it because he wasn't looking for it actually. He was focusing on the papillary muscle rupture and VSR, forgetting that LVOT obstruction is one of the mechanical complications that is worthy of looking for and trying to elicit. So you have to look for it. And in fact, we advise in that patient to lower down the inotropes and give fluid instead. And he improved a lot because the inotropes is gonna vigorously activate the contracting muscle even further and might worsen the LVOT obstruction. So when you slow down on inotropes in these patients and you give fluid to expand the LV cavity, things might be better. Okay, and in fact, the patient has improved on fluids and de-escalation of inotropes. So we have to remember that LVOT obstruction is one of the mechanical complications of MI, and also one of the complications of Takotsubo, stress-induced cardiomyopathy for the same reason and for the same mechanism. So in this patient, Lvo tube obstruction is expected, apical thrombus is expected, severe MR is expected, because with any degree of LV dysfunction, if that was MI, you might have papillary muscle rupture, you might have ischemic papillary muscle tethering the leaflet, and you might have ischemic MR, functional MR, and stuff like that. Normal coronaries is also expected in this patient if it was a stress-induced cardiomyopathy. The thing that has nothing to do with this particular abnormality here is severe aortic regurgitation. Okay? So you get the point here?
Yes, clear. Thank you, Dr. Hatim.
Now, what do we see here?
Okay. This is the lung basin axis view, transthoracic, showing a dilated aorta, diuretic ascending and aortic root with the dissection flap.
Very good. So you are talking about this one, right?
Yes.
This one? Okay. So there is a clear dissection flap in the ascending aorta with significant dilatation of the root. What else do you see here?
Another, there is in the aortic valve looks there is a coarctation defect.
Very good. Yes.
Making a severe AR suspect.
Yes, exactly. So if you put color here and you couldn't see AR, means you are mistaken, because anatomically there must be severe MR because of this wide gap between the cusp, because of the dilated root stretching the cusp out and creating a gap or a hole in the middle. So this patient had severe aortic regurgitation. What else do you see here as well?
The mitral valve.
I see mitral valve myxomatous.
Very good.
Myxomatous mitral
Myxomatous is probably prolapse or flail of the posterior leaf.
most likely Marfan syndrome. Marfan.
Yes, you are so right. And this is important, by the way, because, you know, in the diagnostic world, there is something called search satisficing, meaning when you find the first abnormality, especially when that first abnormality is so impressive and serious, the chances to miss a second and third abnormality is really a lot. So you might glue yourself on this flap and you forget about the mitral valve. You might glue yourself on this flap and you forget that this patient is also having a flap into the descending aorta here. Okay? So this is a search satisficing error. So you or the diagnosticians are usually alerted to this, and they think twice before they close the case at the major abnormality. They look around and see if they have missed anything else. So I wish you also do the same and try to see around after you are done with the major abnormality. Try to look for additional abnormalities. So this is a dissection flap, wide coaptation gap, and myxomatous mitral valve, a patient of Marfan. Here again, if you compare the flap here is a bit proximal. You see my cursor is pointing to a proximal flap, more proximal than this one here. And it is the flap itself that prolapse into the valve plane, impeding its closure. So here, the aortic regurgitation is also severe, but for a different reason. The reason here is that the coaptation of the valve is impaired by the prolapsing flap into it. But here, due to the stretching of the cusp. So these are two mechanisms of aortic regurgitation in type A dissection. Okay. Now, what about this one here? What do you see here? Do you see any abnormality here?
The root and the aortic valve seem to be normal, but there is a dissection flap in the descending thoracic aorta.
Yes, thank you so much. Exactly. So this is a dissection flap down here. see, don't forget this black hole, the descending aorta. So you can see that the flap is here and extending all the way down. So it is involving the ascending arch and descending, or you can find it only here and not here, or you can only find it here and that will be type B dissection when it is not involving the root, when it's not involving the ascending aorta. So in this case, the root and the ascending aorta are not involved, but it's only dissection of the descending aorta, like this one here. Okay, good. Now, what do you see here?
This is a parasternal long axis view. Show dilated left atrium and left ventricle. There is reduced systolic function, and I want the other view to confirm this. There is a mitral regurg.
Very good. Okay, great. So, you want to add anything?
Most likely could be dilated cardiomyopathy. DCM.
Okay, dilated cardiomyopathy. That is so likely. But if you look here, anterior septum compared to the posterior is akinetic. So there was posterior akinesis, or you can call it ipsilateral wall. So
yes.
it was ischemic cardiomyopathy, and it is ischemic cardiomyopathy.
Yes.
Okay. So if this is ischemic cardiomyopathy and you have described the mitral valve as how it looks, can you describe this mitral valve to me? The anterior leaflet is here, the posterior leaflet is here. So what do you
Filial posterior leaflet.
Is it?
No, it's not moving.
Yes,
Yes.
it is moving. Yani compare the mobility here. It's only appreciable at the tip, but the body is not moving. It is tethered down. It is tethered down, you know, because the papillary muscle anchoring on the posterior wall is ischemic, so it pulls the posterior leaflet apically, and that's what you get. You get a coaptation gap like this one here due to the restriction of the posterior leaflet, and you have the mitral regurgitation, which is posteriorly directed. Posteriorly directed, you see, posteriorly directed mitral regurgitation. This is, we call it ischemic mitral regurg. Ischemic mitral regurg. Ischemic mitral regurg is a sort of functional mitral regurgitation, but it has a very peculiar pathology and morphology because of the tethering of a restriction of the posterior leaflet, creating a coaptation gap. Okay, so it looks that as if the anterior leaflet is relatively prolapsing. It's not prolapsing, but it's relatively prolapsing compared to the posterior leaflet. Okay, and now the direction of the jet is posterior and
posterior.
Achievable. Yes, you remember that we said that the direction of the jet can be central or eccentric.
Yes.
Now in prolapse and flail, what's the direction of the MR?
Again, it's in the opposite side.
Yes, exactly. And what about in ischemic MR?
In the ischemic, in the same direction of the affected leaflet.
Thank you so much. And I always ask people to remember the crab. So this is the direction of the MR towards restriction, away from prolapse. So if the prolapse is in the anterior leaflet, the MR is going to be posterior and vice versa. But if the restriction is posterior, the MR is going to be in the direction, in the same direction of the restricted movement, in the restricted leaflet. So it is towards restriction. The MR jet is towards restriction, away from prolapse. Okay? Good? Are you okay?
Okay, fine.
Good, good, good. Okay, now we move on. Now, so in this case, I want you to know now the different type of mitral regurgitation. So this is, I want you to acquaint yourself with how ischemic MR looks like. When we say ischemic MR, that should triggers certain kind of imagery in your mind of a restricted, tethered, apically displaced posterior leaflet and posteriorly directed jet of mitral regurgitation. Okay? Remember this one. Now, this is a bit tough, but I think you might answer it. But this is the parasternal long axis. You see there is a valve here, is a prosthetic valve in the aorta. What is this prosthetic valve?
Looks like TAVI.
Yes, thank you so much. So this is again one of the things you should acquaint yourself with, how the prosthesis looks like in transthoracic and TEE, how they look like, how metallic is different from bio, and how bioprosthesis, surgical bioprosthesis, is different than valve prosthesis. So this is the persona or the fingerprint of TAVI. This is not a surgical valve. This is TAVI. We see it and we خلاص, we know it طوالي بدون أي تعب. This is TAVI valve. So what's the problem with this TAVI valve?
I have some paravalvular leak.
Yes, very good. There is paravalvular leak. This one here. You see, this one is paravalvular leak. Okay.
And mitral regurgitation.
And there is mitral regurgitation. What else?
I think there is a space between the valve and the wall.
There is a space. Yes. Okay. There is a space. And I think it is because of this space you are seeing the paravalvular leak. And if you look at the anterior leaflet, you see the position of the TAVI valve.
Compromising the leaflet.
Because it is low seated. It is low seated. Low seated valve. The valve should be here, here, and it ends here. It just touched the base of the anterior leaflet, but now it is touching down to the mid body of the anterior leaflet. So this is low seated valve, and the low seated valve is usually accompanied with paravalvular leak. Here طبعا it might be high seated and it can be low seated, but most likely you are going to encounter low seated than high seated. لأنه high seated usually the interventionists they have a reflex to avoid high seated valve. لأنه high seated valve مشكلتها ممكن تكون شنو؟ Obstruction of the coronaries.
Yes.
Coronary osteostenosis by the prosthesis. That's why they try to avoid going up, and they might go down instead. Down is not associated with immediate complication like up. Okay? ولذلك في inclination towards going down rather than up. So it's more likely to see low seated than high seated prosthesis. Okay? So the very first thing we comment on when we see a TAVI valve is the positioning of the valve. Is it low seated or it's normally seated? And then is there any paravalvular leak? Okay, then the gradients, how they are, and then the mitral regurgitation. There is a tendency for MR, pre-existing MR, to improve after TAVI. You agree or disagree? يعني البيشنت
agree to some because the volume overload is admitted by severe mitral aortic regurgitation may be improving after the valve placement, but in most of the cases they prefer mitral stenosis and for regurgitation.
Okay. Because of volume of displacement.
And
هي طبعا إذا كان عندك severe aortic stenosis to start with, and let's say severe mitral regurgitation, severe stenosis, and severe mitral regurgitation. So this, when you have an obstruction severe here, when the blood goes in contraction, in systole, and there is a high resistance here, it goes into the left atrium instead, because the resistance in the LV is lower than in here, and that might maximize and increase the MR because of the afterload problem created by the aortic stenosis. So if you eliminate the aortic stenosis, the resistance for the outflow is lowered, and therefore less blood goes into the left atrium. Okay, so there is a reduction. Usually there is a reduction by 1-2 grades of the MR after TAVI. There are so many studies that have documented that the reduction in MR after TAVI. Okay, probably for this reason. Now, in this patient, also there is another problem of low-seated valve like this one. Low-seated valve meaning paravalvular leak because it's not snugging or is not tightly packed against the annulus. That's why you might get, like Victoria mentioned, we have a sort of space because it's not tightly adherent to the annulus. And that's why we get paravalvular leak. But there is another problem, which is something relating to the mitral valve, which is what? It might impair the movement. It might impair the movement of the anterior leaflet. You know, because the prosthesis now is lying upon the anterior leaflet. This is a hardware, heavy hardware lying on the anterior leaflet. So the anterior leaflet is not opening up as it should. And you see here the 3D here. Look at the anterior leaflet. Look at the posterior leaflet. The anterior leaflet is hardly opening because the prosthesis is encroaching upon it. So in this patient, we ended up having obstruction on the tricuspid valve, on the mitral valve, with high gradient or highish gradient on the mitral valve. This is also one of the problems of TAVI prosthesis. When it's low-seated, it can interfere with the mobility movement of the anterior leaflet. Okay, good. So reassure me that you understand this one.
okay, it's good.
Good, all of you? Okay. Now, what is this here you see? What is this?
It's the external long axis view show dilated aortic root, aorta.
Okay.
And aortic valve is not functioning.
Okay.
There is in the other view there is severe aortic rigor.
Severe aortic rigor. Okay, good. Good. This is almost halfway through. And also you can observe that the LV is dilated and mildly or moderately impaired. But I just want to correct you about the aortic valve. The aortic valve is not native. This is a prosthetic aortic valve. This is bioprosthesis, and this is how bioprosthesis looks like. Okay, it looks like this. You have two kind of echodense, you know, struts here, and you see the cusp inside. And you also see this one, which is a shadow artifact. This is called shadow artifact because of this dense material in the strut. So when the ultrasound beam comes like this, it hits this echodense, a shadow is cast upon the other side. Okay, so if you see this one with this shadow, this is bioprosthesis. So this is bioprosthesis aortic valve, and there is aortic regurgitation. But can you tell me about the location of this aortic regurgitation? Where is the location? طبعا whenever you are seeing a prosthesis and you see regurgitation, the first response is to determine from where it comes, from within or from without. Like, is it from within the valve here, intrinsic, or from without? Is it coming from here or from here, and you call it paravalvulally? And if you see here, this is the border of the prosthesis. This one and this one. Yes, exactly. This is severe paravalvular leak of the bioprosthesis. Okay, severe paravalvular leak. Okay, good. And not only that, if you see here again, look at this prosthesis. Can you appreciate a rocking movement? Yes. It's not stable. You know, it's not stable. Yani the prosthesis itself moves up and down. And this is so serious, by the way. That means the dehiscence in the sewing ring is really large. Yani if you have a small hole leading to small paravalvular leak, the prosthesis is going to be stable. But if the dehiscence is large, involving large part of the sewing ring, then the valve stability itself is at stake. And you might appreciate this rocking movement or tilting movement of the valve, up and down movement of the valve, like this one here. So this is large paravalvular leak, large dehiscence, okay, and severe paravalvular leak. Are you expecting this patient to have hemolysis? No, I think you have to answer me.
Yeah.
I'm gonna wait for your answer. I'm not gonna move forward until you answer me.
Because it's bioprosthetic.
Uh-huh.
I'm not suspecting a more severe anemia like a prosthetic valve.
Okay. Yeah, we might go back to the basics. Why paravalvular leak can paravalvular leaks lead to anemia? Are they associated or a cause of anemia?
Maybe because of anemia.
Yes.
Yes.
Yes, certainly, yes. You know, now I have a patient actually still in hospital with paravalvular leak. She had 3 holes of paravalvular leak on the mitral prosthesis. Her main problem is transfusion dependent anemia. Yani we are transfusing her 2 to 3 units every week because of hemolysis. We have checked haptoglobin, it's low. Total bilirubin is high, and we have retics count is high. So all the parameters of hemolysis is in there, okay? So paravalvular leak leads to hemolysis. So paravalvular leak has 2 manifestations. The manifestation of the valve disease itself, like you have paravalvular leak like this one, it has the same effect like aortic regurgitation. If I have paravalvular leak on the mitral prosthesis, it will have the same effect like mitral regurgitation. So this is one effect, the mechanical effect of the valve regurgitation itself because of the paravalvular leak. And it has another special effect, which is the hemolysis. Okay? And this is called microangiopathic hemolytic anemia, because as blood goes through the hole, it gets destroyed. Microangiopathic hemolytic anemia, destroyed through, this is mechanical trauma imposed on the blood by this small hole. So it destroys blood. It's a hole that destroys blood, and this destruction can be severe as to make the patient transfusion dependent. Usually, the destruction of the blood in paravalvular leak is because of a small hole, not large hole. Does that make sense to you?
Yes.
Yes, because it is microangiopathic anemia. So the geometry and the size of the hole has a lot to do with the destruction. If the hole is small, blood is coming into it with high velocity, is more likely to be destroyed. But if the hole is big, the blood is going to go with a slow velocity, relaxedly, and less likely to be destroyed. Okay. So usually the anemia is associated with a smaller paravalvular leak than large paravalvular leaks. Okay, that's why I ask you, are you expecting to see anemia in this patient? And I would expect you to answer not likely, because the hole is big here. It's actually large area of dehiscence. Okay, so remember, I want you to remember that paravalvular leak and their association, or how they cause, it's not an association, it's a cause and effect, how they cause anemia. Okay, and sometimes the indication to close the paravalvular leak is not the patient symptomatic because of the MR or AR, it's because of anemia. We close holes because of anemia, you know, because I told you it can reach a severe degree of being the patient will be hospital ridden for most of the time, and he had this transfusion dependent anemia. Okay, so now what are we seeing on the left? Here.
This is a long prosthetic axis view. Show
Yes.
a biprosthetic mitral valve.
Here, you mean here? Yes, this is a bioprosthetic. Look at it again, all of you. Look at the bioprosthetic valve, and this is how it looks like. So try to familiarize yourself with how the bioprosthesis look like. It looks just like this one. Khalas, this is bioprosthesis. But before this, can you look at this one here?
The anterior mitral leaflet is thickened.
Okay.
With a mass like.
Yes, there is a mass.
A mass.
There is a mass. Actually, the anterior leaflet is not well seen and delineated because it is tightly adherent to the mass. Yes. So you see, I see it here. I see the cords, see here. The cords are here. This one, this is not the anterior leaflet. This is part of the aortic root, but the anterior leaflet is here, and this is the mass. So the mass is prolapsing and attached to the anterior leaflet and prolapsing into the mitral valve, causing severe obstruction. This patient came with severe mitral stenosis and mitral regurgitation as well. And of course, she underwent surgery, and they excised the mass. The mass was attached to the septum with broad base attachment. So what's the likely diagnosis? So what's the likely diagnosis here?
To be fibroblastima.
Fibroblastima or?
Myxoma.
Yes, it's more likely given the size and the attachment to the septum and its relationship to the mitral valve to be myxoma. And that's what we all thought of. we thought this is myxoma. And the patient underwent successful total excision of the mass and mitral valve replacement. Why did we replace the valve? Because the surgeon found that the anterior leaflet is damaged. It is fibrotic. So he replaced the valve. Of course, are you going to throw this piece of meat or you are going to send it to histopathology?
We'll send it to histopathology.
Of course. Whatever it looks to you visually, you have to have a histopathology diagnosis. Now, this patient came 3 months later. See what we found. This is the bioprofis. You see it here, I'm zooming in. And now we have a mass. This time is below the valve. And it is prolapsing in the LVOT, obstructing the LVOT. You see how the LVOT, this is the aortic valve. You see how it sneaks and gets incarcerated on and off into the aortic valve, causing severe LVOT aortic valve obstruction. So what the heck is this? It is in the behavior of myxoma. And yes, that was sarcoma. And the histopathology has confirmed sarcoma. And the patient actually, before this stage, was advised to go for chemo and radio and was sent to oncology, but the patient refused all treatment and unfortunately came back with recurrence of the mass and in below the valve and obstructing the LVOT. So though it looks to us as myxoma, the histopathology was sarcoma. And I want to remind you that sarcoma or angiosarcoma is the most common primary cardiac malignancy. The most common primary cardiac malignancy is angiosarcoma. The most common benign primary cardiac tumor is myxoma. Okay, and the most common malignant tumor involvement of the heart is metastatic. So the heart is more likely to be a seed of metastasis than to have a malignant tumor arising from within. This is important. But if we have a tumor that arises from within the heart as primary cardiac tumor, is most likely angiosarcoma. Okay.
Yes, good.
Okay. Okay, so now what are we seeing here? Or, you know, I'll tell you something, because this is a bit maybe advanced. We are going to go for a separate topic about LV diastolic function and how it's to be assessed and how it translates into clinical data later maybe. So I'm going to skip this one. Okay. Now, what are we seeing here?
This is an empiric hemodynamic tracing.
Very good. Uh-huh.
In the A, this is hemodynamic tracing for LV simultaneous hemodynamic tracing.
Okay.
For LV and aorta,
Okay.
it's scaling from 0 to 160.
Okay.
Showing after the fifth wave, after the BVCs, we see an increasing gradient between the LV and aorta.
Very good. You are talking about this one?
Yes, think about this one.
So after the PVC, there is an increase in the gradient. Okay.
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 The gradient was between 120 to 80, 40. Then scaling between 160 to 120.
Okay.
Okay. And
what about the second one?
Okay. Here, after the PVC, there is an increase in gradient.
Okay.
More obvious than the before. That the pressure is increasing, but the gradient is the same. But in the second, is more obvious increasing in the gradient.
Okay. Good. Good. Thank you, Dr. Rabah. So I think you have done great. Any other fine tuning? Yani Rabah said that we have an increasing gradient in both hemodynamic tracing, but here is more pronounced after the PVC. And this is expected, by the way, because after the PVC, you have a pause, after which there is more of diastolic filling. So the strength of contraction is going to be more. That's why the strength of contraction means here that the LV pressure is high. And that maximizes the gradient or increases the gradient compared to the baseline. And this has been seen in both conditions, here and here. We have increased gradient compared to baseline, and we have here a more pronounced increased gradient compared to the baseline. So what are we dealing with here and what we are dealing with here?
See, in the first, with the normal phenomena kind of care. In the second, we're dealing with an LV obstruction, LVOT obstruction.
Okay. Okay. Good. So Rabah said this is LVOT obstruction, meaning Hookham, let's say, hypertrophic obstructive cardiomyopathy is here. But this is normal, lakin I'm against this called normal, because a normal, you have the LV and aorta systolic pressure are equal. Why I have this gap? Why I have gradient between the aorta and the LV? There must be some degree of aortic stenosis. Once I have this separation between the two curves, the aortic curve and the LV curve, meaning I'm dealing with aortic stenosis.
Yes, aortic stenosis.
Okay, so there is an aortic stenosis here. The only difference is this is fixed aortic stenosis because of aortic stenosis, and this is dynamic aortic obstruction due to Hookham. And this is how the hemodynamics differ. The most crucial element in the difference between these two tracing is what? The PP, the pulse pressure. You look at the pulse pressure. Yes, the gradient increases in both, but look at the pulse pressure. The difference between the peak and the diastolic, the peak systolic and the diastolic. In fixed aortic stenosis, it gets prolonged. In Hookham, it is narrowed compared to the baseline. It is narrowed compared to the baseline. And this is called what? Broken-Bro sign. This is the Broken-Bro sign of Hookham in invasive hemodynamics. This is consistent with Hookham. It's the unequivocal sign of hypertrophic obstructive cardiomyopathy in invasive hemodynamics. This is how they used to diagnose Hookham decades ago, because there was no echo. It was basically invasive hemodynamics. So they use this one. They induce a PVC and they see how the pulse pressure behaves before and after. They don't look at the increasing gradient because this is expected in fixed or dynamic obstruction. But the most important thing is the drop in the pulse pressure as compared to the fixed stenosis in which there is prolongation of the pulse pressure. So this is brocomprosine. What is brocomprosine? So what's the brocomprosine? It's the narrowing of the pulse pressure after the PVC. It is not the increasing gradient after the PVC, because that's not going to tell you the difference between the two, because in both you have prolongation of the gradient or increase in the gradient. The difference between fixed and dynamic obstruction is this PP, pulse pressure, prolongation and narrowing. Okay? So,
yeah. Okay.
that fine?
Fine.
Good. Now, what are we seeing here?
This is mitral valve clipping.
Yes. This is mitral clip. And I meant in this presentation to tour you and probably confuse you about so many topics in cardiology to stimulate your reading and to give you main point, okay? But I didn't mean to give a particular topic about particular stuff, because we might later take each separate topic individually in a session and discuss it in depth. But here I'm trying to go in bits and pieces like I told you. Okay, so I'm gonna review with you quickly in less than 5 minutes the so-called structural heart disease intervention or valve intervention, percutaneous valve intervention. One of which is a mitral clip. This is how mitral clip is done. In this video, animated video, you see they go like this and they test the perpendicularity. They have to come perpendicular. They have to be perpendicular. See how they are testing the perpendicularity? Because I have to, sorry. They have to come this way. If they are oblique, there are the risk of no adequate grasp. So the mitral regurgitation is not going to be eliminated. And worse, there is a risk of clip detachment, because the stability of the clip with oblique orientation is not as with perpendicular orientation. So the perpendicularity of the clip deployment ensures two things. One, stability and efficacy. Okay. So who is gonna guide the interventionist to deploy the clip in the right position? Huh?
The echocardiography.
Yes. And that's why now we are seeing the echocardiologists are seen in cath lab more frequent than they used to because of the interventional structural heart disease like this. So this is fully guided procedure, fully from A to Z. You have to guide the interventionist to the proper piercing of the septum, because they come from the right side and pierce the interatrial septum to go to the left side. So where should they go and how they go, you are going to guide them. And most importantly, you are going to guide them to the proper positioning and ensuring stability of the clip. And then after they deploy the clip like this one here, see, this is how they grasp. So when they grasp, you are following all of these steps. They grasp, and then you are going to check on the MR. Is the MR eliminated and how much is reduced? Okay. You might put another clip if the result wasn't so optimal, or you might change the position of the clip to ensure a better efficacy and stuff like that. This is all by crosstalk between the interventionist and echocardiographist. Okay. So this is the mitral clip procedure. Now, The indication for mitral clip, which patient is selected for mitral clip?
Innovation is severe symptomatic severe mitral regurgitation that not fit for surgery.
Yes. So patients who are eligible to go for surgery because of severe MR, symptomatic or severe MR, LV dysfunction, but they have high or prohibitive surgical risk. So in this case, I have to go for mitral clip. They call it in the guidelines, and they stressed on it in even heart failure management as TEER, T-E-E-R, which is transcutaneous edge-to-edge repair. So they don't call it clip in the guideline. You are not gonna find clip word in the guidelines. It's called TEER or PEER, P-E-E-R, percutaneous edge-to-edge repair. Whenever you see that in the guidelines, they are referring to mitral clip or tricuspid clip. Also tricuspid, they go by the same steps to clip the tricuspid valve. Okay. Now look at this here and tell me what you are seeing.
This is TAVI.
Yeah, this is TAVI, and TAVI is the longest or the most initial valve intervention, percutaneous intervention. It's now more than 15 years or so in the market and in the cardiology centers, and it is just like this one. You go through the aortic valve and you inflate the valve, which is a stent-like valve. And here it is crucial to position your valve in the right. So you don't go so low, like low-seated, because we know that low-seated means paravalvular leak and means compromise of the mitral valve system. And you don't have to go above, because above you are gonna occlude the ostium or the ostia of the coronary artery, and that might be disastrous. So you have to appropriately position your valve. And in this case, are you guided by TEE or fluoro?
These things pause.
Hmm? Yeah. Is it TEE guided procedure? Is it TEE guided procedure? No, it is not. It is fluoroscopy guided procedure. So fluoro, it's only fluoro. We don't go with them. No echo is required to guide. Yeah, there is an echo which is important to ensure the positioning after they deploy it. And if there are any complication, they might call the echocardiologist to come and see. But the procedure is itself, because first of all, you don't have to pierce the septum. You go through the femoral artery and you come all the way here and you position your valve under fluoro guidance and you inflate and come out. Okay, so this is the procedure. But there is an important assessment for TAVI prior to the procedure itself, and that is what? And I know TAVI is not yet in Sudan. That's probably you might not be acquainted with the details of the procedure. But as far as the fellowship program is concerned, you have to have a grasp of all these advanced interventional procedures. You have to know them so well, okay? Because you are the generation who is gonna initiate these procedures in Sudan. So not only that, but because I will, if I come as an external examiner to you there, I'm definitely gonna ask you about them. Okay, so this one. So remember, okay, if I don't remind me, don't remind me, okay, I'm gonna ask you about it. So this is the TAVI. One, it's important for TAVI to do cardiac CT. So cardiac CT is now routine before TAVI. Because they need to assess what? They need to assess the annulus, the calcification, the ostial takeoff, how far the coronary ostia from the annulus. If it is less than 1 centimeter, the TAVI prosthesis might be dangerous because it's long and might encroach upon the ostia. These are all data collected from cardiac CT. Plus, they also in cardiac CT, they are going to show you the peripheral vasculature, the femoral arteries, okay, the aorta, and all of that. And you see how much calcium and the size. Will the size allow for accommodating the sheath of the TAVI or not? Okay, so it's going to tell you about the peripheral axes, and it's going to tell you about the favorability of the anatomy at the aortic valve level. This is the cardiac CT. So cardiac CT is important before TAVI. Okay. Now, tell me, what is this?
Balloon angioplasty. Balloon dilatation.
Of what?
The aortic valve.
Is it aortic valve or
sorry, pulmonary valve.
No, it is aortic valve. But is it native or prosthetic aortic valve? It is prosthetic aortic valve. This is prosthetic aortic valve, and this is implantation of a percutaneous valve on top of a prosthetic valve. So what is this? What is this? This is called what? What's the name of this procedure? Valve in valve procedure. Okay. So when you read in the guidelines, and you will find valve in valve procedure. So you have a prosthetic valve and you put a new valve into it. Why? Why? Because the prosthetic valve is degenerative, is stenotic, or regurgitant, incompetent, okay? And the patient have high surgical risk, cannot go for redo surgery. So instead, we are going to take him to the cath lab and put a valve on valve. So a prosthetic valve, just like the TAVI one, is stent-like valve, and we inflate it upon the sewing ring of the prosthetic valve, and now we have a new valve. Okay, so this is called valve in valve. Okay, this is partially TE guided. It's not like clip. Clip is 100% TE guided. TAVI is not TE guided, it's fluoro guided. Valve in valve, they need the TE for some steps and not the others, but it's also partially TE guided. Now, what is this? What is this? What are these? Strange stuff here. This is paravalvular leak, percutaneous occlusion. And if you have paravalvular leak, you either have to take your patient to surgery, okay, to replace the valve, and this is redo surgery with high risk. So if the patient is high risk, you have the option of percutaneous intervention. And how with that, you define where the leak is, and then you go by a catheter and you negotiate through the hole. And this is also TE guided, where the hole is, and through the wire, you put a plug, implant device, occluder device, you put it into this hole and you occlude the hole. Like this one here, you see this disc, it's called the plug, okay? This is occluder device for a paravalvular leak, okay? So you are gonna be guided by TE, just like this one here. We are gonna show them where to put the wire, how to inflate or deploy the occluder device, and we check the competency of occlusion and all of that. This is all TE guided. This is another percutaneous procedure. So as far as the structural heart disease is concerned, I would like you to remember the percutaneous occluder device, the valve involved, the TAVI, and the clip, or tear or pier, transcutaneous edge-to-edge repair. Okay, so thank you so much. We are gonna stop here. And
Okay, thank you, Dr. Hatim.
thank
Jazakallah
you.
khair.
Thank you so much.